Right. Hey, everyone. Thanks for joining us today for this Surreal DB Studio session. And thank you so much for my lovely guests for being present with me today for this conversation. I'd like to start off with some welcome and introductions. So my name is Naira Hussain, and I lead the developer relations team here at Surreal DB. And perhaps we can go on to each one of you.
Okay, my name is Caroline Morton. I trained as a GP and an epidemiologist, and I work with Rohini at Queen Mary University on a project called Genes and Health, and I also run a business with Max called Yellowbird Consulting.
Hello everyone, I'm Rohini Mathur. I'm a professor and chair of health data science at Queen Mary University of London. I'm an epidemiologist by training, and I work mainly in health inequalities in Genes and Health with Caroline and the Clinical Effectiveness Group, an organisation which supports quality improvement in healthcare.
Hi, I'm Max O'Flynn. I'm a senior Rust engineer at SurrealDB. I used to be a nurse, and I have a clinical background in that sense, and then I left the NHS, studied physics, and became a software engineer, but still did quite a bit of work with Caroline, and we did some computational medicine at Imperial College, and just keep working together, it seems.
Yeah.
Right. And for the developers in the audience, I come with a backend development and machine learning background. So I've spent about 5 to 6 years with this experience. And we can start speaking a bit more about that, about how important it is to have good data when it comes to working in safety critical systems, for example, like the healthcare industry. Typically, for machine learning engineers, about 80% of the work goes in cleaning the data, collecting, cleaning, making sure you have the right quality data for the use case or the problem you're trying to solve. So perhaps we could shed some light about that.
I think that's a very similar, I would say that's a similar metric probably in health data science. So epidemiologists and other people who work with health data, they are writing statistical code. I mean, certainly it's been my experience that 80 to 90% of the code that you write is cleaning the data, and it is quite messy data, it can be.
Absolutely, and I think when we're using these data to make clinical decisions or develop an evidence base, we want to be really careful about being sure about what the data mean, understanding how they were collected. And so a lot of data cleaning in healthcare settings is actually about understanding the context. A lot of these data aren't collected for research purposes, and so they may be messy, they may not capture the thing you're interested in. So we have to think about all of these potential biases when working with health data.
And from my clinical days, I remember when working in A&E, you'd sometimes treat a patient, then maybe write the notes like an hour later, that sort of thing, right?
Or the next day.
Yeah, so, and it's because the patient's sick, you can't really write the notes the minute you do it. So I think healthcare is just one of the most messy data sets that I've seen, just out of practicalities. You just can't really record it really that accurately. And then you get the different codes, which I'm sure the other two people talk about in terms of the different ways we categorize.
So, I mean, a lot of so basically the way that health data is coded in the NHS is, and internationally I would say, is you use either ICD-10 codes, and in the UK we use that primarily for secondary care, so hospital medicine, and then SNOMED codes for primary care. And so, it's one of those things you can only capture what's been coded, and researchers like us, we don't get the free text that goes along with those codes. So while your GP may have written diabetes and given a diabetes code, what we don't have is some of the history around that. So symptoms first presented in 2015, that is completely lost. So and that is removed primarily for data privacy reasons, and also like unstructured data is quite difficult to deal with at scale if you imagine how many people use the NHS. So that's one of the big challenges, I would say. And then the SNOMED codes and ICD-10 codes have the same problem, that I might code something completely differently to how somebody else might code. And when I say code, I mean picking the SNOMED code. So, I might use diabetes, but somebody else might use diabetic review. Okay, so I think I once counted there's something like 140 different ways that you can denote someone has diabetes. So when you're writing research code, you have to make sure that you can capture all of that.
Yeah, absolutely. And I think, working with NHS data increasingly in trusted research environments where we can actually link to other kinds of data, particularly from hospitals, like lab results or imaging data, we're now, at a time where we can actually make good use of very rich data in addition to the coded data to help understand health conditions in a bit more detail.
That's quite interesting. So it seems like we're in a space where the data has to be highly contextualized so that you understand the background of the patient's history before you're trying to approach solving a problem. Max, earlier today we heard you speak about the machine learning feature on the stage in SurrealDB, which sounded quite interesting as well, about how you can you can inference a model directly from within the database. So perhaps you could speak a bit about that and the impact you see on the data science field.
Yeah, so I've been very lucky to see like two sides in terms of like software engineering in commercial and also the way software is written in the NHS. And there's a few things that and this is why I kind of pushed to work on it and we open sourced it and stuff like this, is there's a few really small benefits which actually have huge knock-on effects, huge benefits in the long run. And one of them is that coding in the NHS is still quite new, software engineering. So they do a lot of machine learning or something like this. They'll pick it in a file, save the model, and then they'll just send it to their colleague. And then you could accidentally just put in the wrong inputs in the wrong order, or you don't normalize the data. And to go back, I said this in my talk, but it's a very important point. Some of the biggest clinical errors that I've seen are just very basic, like you don't have your wristband on the patient, or someone forgot to order the bloods, or someone forgot to note the bloods, and I'm sure that we're having these sorts of errors as well in the way that we distribute machine learning models. So this is why, instead of trying to go down the super glamorous way of trying to come up with a new model or something like this, I really wanted to focus on building an open source file that had all the metadata for that machine learning model, so you just don't get those errors. And then how it executes in the database is that we have SurrealQL, so you can actually write. You can actually start to compare the versions of the machine learning model. So you could have version 1 or version 2, and in your SurrealQL, you can run both of them, and you can do queries for both and actually compare the differences. And this gives us a lot of flexibility in terms of being able to directly compare how different machine learning models or different models in general affect the selection. So you could actually just get two queries and see what the differences are straight away. So it gives you more transparency in how these things are calculated. Because there's a big worry in healthcare in terms of like these machine learning models. Do we actually know how they're calculating these things? You hear the term black box a lot. So
you do hear that term, and I think I'm not a lawyer, but it seems like there is a potential minefield there of if the machine learning algorithm makes a mistake or just gets the wrong diagnosis or whatever, then who's really to blame? And so I think we need to really increase the transparency. I mean, is it the machine or is it the person who put the inputs in? There's lots of unknowns, especially when it comes to people's health. And I think that applies to lots of different industries, but obviously it's very personal when you're dealing with your health.
Yeah, it sounds like we're approaching the same puzzle from two different ends. We're increasingly seeing more regulation around this, seeing AI being categorized into high risk, limited risk, and low risk. So I'm sure, especially in the healthcare industry, you can see we have a lot of regulation as it is, before this AI regulation is brought into place. So I was wondering, what are your thoughts on balancing working in the secure analytics environment along with open source and open methods in data science?
So I think the data has to be in a secure environment. So I think when we started out, the data wasn't necessarily held in these what we call a trusted research environment, which is essentially a virtual machine that you can log into and you can execute your code. It was mostly held in trusted sites, which you could physically access. And that is increasingly less popular. There's also a lot more data that you take into account. So we've both worked with various different data sets. And should we talk a bit about OpenSafely? So OpenSafely is a trusted research environment that was set up during the COVID outbreak. and it's got 17 million people's records in it. It's built directly into it's housed in the database company that holds quite a lot of the NHS records. And I would say it's a very secure approach. So I'm giving you one example.
Yep.
So in this example, you write your code completely independently of the data,
Right.
and but there is some dummy data, but it's not really good enough to write really good to use to its full advantage. So that's one of the problems. But you write your code completely outside. You never have access to the raw code, and then you send it off in a data pipeline, and then the results pop back out. So that's like one end of the spectrum. A more common thing with trusted research environments is that you physically, you log in to the environment, and then the data is flat CSV files of SNOMED codes with some, obviously like date of birth and name and address and all that stuff is removed. And you write your code in there and you execute it. So there's pros and cons of both approaches, but I'm not sure which way it's going to go in the end.
I think one thing coming from an academic perspective, having worked with data living somewhere secure but where you can still touch it, is that using a platform like Open Safely sort of forced us to use open methods and sharing approaches, because we all had to learn from scratch how to access trusted research environments, how to use programming languages to interrogate data that we couldn't see, test our assumptions. And so it was really beneficial, I think, in a way for upskilling a cohort of people, epidemiologists, researchers who'd worked in one way for a long time, and really kind of pushed us forward into the future a bit.
And also as well, I'd like to build on the regulation kind of side, and I think this is why our collaboration is always quite exciting, because we come from, we've got the commercial software and the healthcare. These fields can offer so much in terms of benefits to other fields. So the aviation industry actually taught the medical industry a lot about safety checklists, that sort of thing, because they're just really good at getting a flight, which is quite dangerous, and having really good success rates. So whenever you go through clinical training, you have this thing, and they tell you about the aviation standards and how they actually brought in people from the aviation industry to reduce errors in surgical procedures. This can also have the effect in tech, right? So healthcare has a really good experience in regulation in terms of preventing harm to users. And I think collaborations with healthcare systems are very important, because we can actually learn from them like they learn from the aviation industry on how to prevent harm. Because when it comes to machine learning and other things, we are seeing now in the news software systems actually harming people. They get stuff wrong, they make wrong calculations, or there's bugs, and you hear it in the news now. It's becoming more and more popular. So I hope that these collaborations with healthcare systems, we can learn a lot in terms of how to actually regulate and monitor outcomes.
Great, thanks for that, Max. You did mention about using dummy data and the two different approaches, using a highly secure environment versus I guess more of a DIY approach with some dummy data. I am wondering about, have you thought about a synthetic data source as a potential solution for this?
Yeah, so there's been quite a lot of thought going in across across the years of how you could generate synthetic data, essentially. And there's been various different approaches, I would say, and I think there's many ways you could do it. Some have used Bayesian statistics, some have just sort of raw computed things, and some have just used random data, essentially, or generated random data. They have their pros and cons. I think the really exciting thing about using SerealDB, and particularly using the graph approach, is it does allow us potentially to really capture the complexity of what this domain is. So with the SNOMED codes being arranged in this graph, we really want to be able to traverse the graph and generate data based on that. And as far as I know, that's not been done that much. I mean, obviously lots of people have worked with dummy data in the past, but I think we could really improve it to make it more usable. And really I think we're both interested in this, is what we want to do is we want to encourage change. So we want it to become normal. Like my dream is in the future, it's totally normal when you release a scientific paper that you release both the code that ran that, like produced these results, and a synthetic data set that goes alongside it. So if you're in the field or you're a reviewer of that paper or a student who's learning epidemiology or medicine, you can go and have a look at it, have a play around with the fake data and learn. And I think that makes things more believable. There's also a practical aspect of that. We'll hopefully catch more errors and improve practices and stop repetition. But
Right.
Yeah, and I think, from my perspective, training the next generation of epidemiologists, scientists, researchers, synthetic data is absolutely essential. If you think about a model like the Open Safely environment, where you have to develop all of your code outside, you don't see the data and your results come back. Unless you're actually quite a skilled epidemiologist or programmer, there's no way to check whether the results you've got are reasonable, whether they make sense. Because, as I said, data is messy, it has to be considered in context. Data may be missing for reasons we don't know. It may be miscoded for the reasons that, Caroline and Max discussed. And so actually being able to train people on synthetic data, which resembles real data and importantly has the same relationships as real data and the same pitfalls as real data, is absolutely game-changing.
That's amazing.
it
And
has
Max,
to be messy. Yeah.
sorry. And Max, if you could shed some light on how SurrealDB can help represent this synthetic data or encourage and revolutionize this change in the healthcare data science.
Yeah, so we have been working together on coming up with actual practical applications here. It's so it's not just pie in the sky. Oh, we could do this X, Y, Z. It's so we use like the graph-like structure, and we can use weights, and we can actually start to do predictions and weighted kind of relationships. And Caroline, did a very good way of demonstrating this in her talk earlier on, where you can have one kind of one kind of illness, but it's so many different ways in which it manifests in the data in terms of how it's coded and how the relationships are. And I'm going to quote Caroline, actually. One of your favorite statements, I think, when you're trying to explain how things map is you have to manually also work out what's logical, because you could theoretically say that the buying cigarette lighters can increase your risk of lung cancer, which obviously is not really a direct correlation.
I totally stole that from Neil Pearce at the London School of Hygiene and Tropical Medicine. That was what he used to teach us with, as an example.
Maybe one day he'll tell us where he got that from. Maybe.
Yeah. So basically, it's like if you do a study and you measured prevalence of owning a cigarette lighter and lung cancer, there would be a very close relationship. But we know logically that cigarette lighters don't cause cancer.
And that's an extreme example, but then we can also find false correlations in other things that we just, they're not as very obvious. So that's where the graph-like nature really, really helps. And there's this, cyclic graphs that you can kind of do, which is quite standard in epidemiology anyway, right? You guys have intelligently come up with solutions for this. It's not like we're telling you how to do epidemiology. But our graph system can actually help them implement this. And I also think as well, building on the open nature, I don't know too much, but from the COVID, news lines and so on, from what I did glean from it is if we try and increase the openness of how things are reported, there's less risk of conspiracy theories being thrown up, because there were bands of people saying, oh, well, people are classifying COVID patients this way or this way. And it's like, yeah, the classification in general is quite messy. It's not just limited to this disease.
Absolutely. Yeah. I mean, the real data, it can be so messy. So I think one of my first studies was when I did a master's, and I used some of your data, actually. And one of the risk factors that we were looking at was blood pressure. So, high blood pressure, you could be coded in the system as having high blood pressure. So that's one way of representing it, and there's like loads of codes which might represent that. But then you've also got to take into account an actual blood pressure that's high and be able to address that. So it's like the data can be very messy. There's lots of it can be missing, and sometimes that can be tricky because you think, well, is it genuinely missing, or is it that it hasn't been transferred across from the data store? And so, yeah, we need to deal. So in addition to having the complexity of the data, we also need to, the raw data, but we also need to deal with the complexity of, well, actually sometimes stuff is just missing.
Yep.
Or someone's put in an empty string, which should have been a blood pressure, for example.
Right. Sorry. We have about a minute, so to wrap up really quickly, perhaps we could touch upon what can we now do to make sure there's this cultural shift in the research community around using more open methods, as well as being able to share your code and your synthetic data that you use.
So, I think changing culture is hard, and I think, from an academic perspective, what maybe move this forward is actually requiring the publishing of code and synthetic data where available by journals who publish our research, by websites that hold our research. I think, there's sort of a carrot and stick approach. I think if you make it mandatory, people will just fall in line. And I think, and actually peer pressure, being encouraged to do it by seeing their peers doing it is how it will work.
Yeah, I totally agree with that. I think we really need to tackle this at a multi-level, but really the thing which makes academic careers is papers published, conferences attended, and we need to tackle journals. We also need to tackle funders, so big organisations which fund these research, multi-million-pound grants for research. If we can get them to insist that the code is shared and there is a synthetic data set, I think that will go a huge way. And then there's sort of not just the stick approach, there's the carrot approach. We need to provide training for people.
Yep.
And Rohini is going to be setting up the Health Data Science Masters at Queen Mary, and you've been involved at the one at LSHTM. So that is coming along as well. So we need to train people, teaching people how to use GitHub, how to do code reviews, and also the professors who are in charge of these departments encouraging and rewarding people for sharing their code and for reviewing other people's code, because it can be a thankless task.
I just have, same as wrapping up, I just have to say, thanks to you two guys as well, because I think viewers need to acknowledge that. I'm not too more familiar with you. I'm more familiar with Caroline because I've known her longer, but Caroline's had a very distinguished career at Oxford, doing the COVID data and so on with Ben Goldacre, and she's written quite a few publications, and it would have been much easier for her to just keep churning out publications in the traditional sense and would have had a very good career. But instead, she stepped back and said, we need to actually make things safer, which is a bit more ambiguous in terms of a bit more treacherous, but I actually think it's a very noble thing.
Thanks very much. That's very sweet.
Well, I'd just like to take a minute to thank you all for attending this panel today and sharing your expertise with us as well as the online audience.
Thanks very much for having us.
Yeah, thank you.